This is a simulation of endolymphatic hydrops, a physical buildup of fluid pressure within the enclosed labyrinth of the inner ear, causing the walls to distend. Historically, the medical community defined Meniere's disease entirely by this mechanical fluid dynamic, attempting to explain the resulting vertigo, hearing loss, and tinnitus as symptoms of pressure. Contemporary neuroaudiological research reveals that this purely mechanical view is incomplete. Treating the fluid accumulation addresses a structural outcome, but it ignores the underlying cellular failure that allows the fluid to leak in the first place. Meniere's disease is increasingly classified in the clinical literature as a progressive cochlear neurodegenerative disorder, driven by systemic metabolic dysregulation and aberrant immune responses. The physical swelling of the inner ear is a downstream consequence of microvascular ischemic damage. The root cause is severe, uncompensated oxidative stress. An overwhelming excess of reactive oxygen species, or ROS, attacks the highly metabolically active cells of the stria vascularis within the cochlea. This targeted oxidative assault disrupts the blood labyrinth barrier, degrading the microvascular walls and allowing fluid to uncontrollably leak into the surrounding tissues. The primary biological marker of this pathological collapse is the severe depletion of glutathione, or GSH. Glutathione is the primary intracellular antioxidant, neutralizing reactive oxygen species before they destroy cellular membranes. Because Meniere's disease is driven by metabolic and microvascular decay, effective therapy must prioritize deep cellular metabolic rescue. Superficial fluid management via diuretics cannot stop the ongoing destruction of inner ear cells. If glutathione depletion is the primary biological driver, the logical clinical question is why doctors do not simply prescribe oral preformed glutathione. The intact glutathione tripeptide is notoriously inefficient as an oral supplement. As it travels through the gastrointestinal tract and blood plasma, enzymes called peptidases rapidly hydrolyze, or break apart, the molecule before it can be utilized. Even if intact glutathione survives systemic circulation, it faces tight physiological blockades. The molecule cannot easily cross the blood-brain barrier, nor can it penetrate the lipophilic cellular membranes guarding the structures of the inner ear. Because the intact molecule cannot be delivered effectively, intervention must rely on a different delivery mechanism. We must provide the precise, rate-limiting precursor amino acids, forcing the cells of the inner ear to synthesize their own glutathione intracellularly. Intracellular glutathione synthesis is a highly regulated two-step enzymatic process. This molecular schematic tracks the first step. The enzyme gamma-GC catalyzes the amino acids glutamate and cysteine, forming an intermediate dipeptide. In the second step, glutathione synthetase fuses a distinct glycine molecule onto that dipeptide, completing the active antioxidant tripeptide, GSH. Clinical medicine extensively utilizes N-acetylcysteine, or NAC, as a highly bioavailable sulfur donor to rapidly replenish cysteine. It is frequently prescribed to protect the inner ear against acute ototoxicity from chemotherapy agents. Clinical trials evaluating NAC monotherapy for chronic sensory neural hearing loss have yielded mixed results. Flooding the cell with massive amounts of cysteine via NAC rapidly exhausts endogenous glycine reserves. Without glycine, the glutathione synthetase enzyme stalls, halting GSH production. Isolated high-dose NAC also introduces a paradoxical danger. It can alter essential trace element homeostasis, reducing cellular concentrations of zinc and copper, and occasionally inhibiting NRF2, a critical transcription factor required for initiating antioxidant responses. NAC monotherapy is biochemically incomplete. Its efficacy in chronic metabolic conditions relies on the concurrent synergistic administration of exogenous glycine. Double-blinded, randomized controlled clinical trials evaluating the combination of glycine and NAC, termed GlyNAC, have produced highly robust data across older adults and patients with metabolic disease. This table illustrates baseline deficits. Subjects showed severely suppressed mitochondrial fatty acid oxidation, or MFO, and elevated insulin resistance. Following GlyNAC supplementation, MFO upregulates by 78%, while insulin resistance drops to healthy baselines. The trial also documented complete resolution of chronic endothelial dysfunction. These specific systemic reversals map directly onto the precise cellular deficits causing Meniere's disease in the inner ear. The stria vascularis demands immense, uninterrupted mitochondrial energy to maintain the endocochlear potential, the biological battery that powers our ability to hear. By aggressively restoring efficient mitochondrial bioenergetics and shielding the microvasculature from oxidative destruction, GlyNAC preserves the physiological machinery required to halt stromal edema and arrest the progression of Meniere's disease. Beyond chronic structural preservation, Meniere's disease requires the acute management of its most functionally disabling symptom, the unpredictable vertigo attack. To recover from a sudden vertiginous episode, the central nervous system must rapidly execute vestibular compensation. This is a highly complex neurochemical recalibration following a unilateral pressure insult from the fluctuating inner ear. This neural schematic focuses on an active synapse within the medial vestibular nucleus. During an acute attack, specific postsynaptic histamine receptors activate. This triggers the presynaptic neuron to release a massive compensatory wave of glycine molecules directly into the synaptic cleft. Glycine functions as a primary inhibitory neurotransmitter, regulating the balance between neuronal excitation and suppression. As glycine molecules bind to postsynaptic receptors, they directly dampen and stabilize the chaotic, hyperactive electrical signaling originating from the damaged inner ear. Conventional management frequently utilizes synthetic vestibular scussants, like benzodiazepines. These artificially dampen neural activity, but induce cognitive blunting and heavy systemic sedation. Administering high-dose exogenous glycine safely repletes the endogenous inhibitory pool. This specific amino acid supply allows the brainstem to achieve a rapid, robust compensatory state, suppressing vertigo naturally without synthetic sedation. The most definitive clinical validation of glutathione pathway in neuroautology comes from the recent STOP-MD3 Phase 3 clinical trial. Following this landmark trial, the U.S. Food and Drug Administration granted formal breakthrough therapy designation to a synthetic compound called SPI-1005, also known as Ebselen, specifically for the treatment of hearing loss in Meniere's disease. This dual pane biochemical flowchart illustrates the mechanism of action. In the left pane, the synthetic Ebselen molecule acts strictly as a glutathione peroxidase, or GPX, mimetic. It neutralizes highly toxic hydrogen peroxide within the cochlea. Endogenous GPX utilizes glutathione to terminate lipid peroxidation. Compare this synthetic approach with GlyNAC's endogenous action. Precursors rapidly fuel natural GSH production. Both the synthetic mimetic and endogenous approaches converge on the exact same outcome, neutralizing the hydrogen peroxide threat. However, isolated synthetic antioxidants carry distinct risks. High acute doses of Ebselen trigger a dangerous hormetic effect, paradoxically reducing mitochondrial oxygen consumption and inducing severe redox stress within the cell. GlyNAC circumvents these synthetic toxicities. By relying entirely on the body's auto-regulated amino acid metabolism, it endogenously fuels the exact same proven enzymatic cascade to restore hearing thresholds without risking mitochondrial suppression. Translating this mechanism into clinical practice requires highly specific weight-based dosing parameters. The successful 24-week human GlyNAC trials utilized a standardized dose of 100 milligrams per kilogram per day of both glycine and NAC. To maximize bioavailability, both amino acids must be co-administered simultaneously. This prevents the rapid systemic oxidation of unbound cysteine into cysteine, a much less useful disulfide molecule. Long-term studies show a consistent safety profile for this protocol over extended treatment durations. Biochemical monitoring reveals no adverse elevations in hepatotoxicity markers or renal impairment. Cautionary tone. There is, however, a primary clinical caveat requiring strict medical oversight for Meniere's patients: hypotensive synergism. Both NAC and glycine possess intrinsic vasodilatory properties. When co-administered at high doses, they can severely compound with pre-existing cardiovascular conditions or prescription antihypertensive medications. Even brief episodes of systemic hypotension can decrease blood flow to the peripheral vestibular system. This inadvertently exacerbates local ischemia and can trigger the exact acute dizziness the patient is trying to prevent. By specifically and safely bridging the unique metabolic, structural, and neurochemical deficits of the Meniere's disease phenotype, GlyNAC supplementation emerges as a highly rational and scientifically validated foundational adjunct to modern neurotological protocols.